Hello, everyone, and welcome. I hope that everyone's enjoying the NLP Summit so far. There certainly are some fascinating topics, so I hope that everybody is learning and having fun with it. My name is Lawrence Rasulian. I'm the head of biostatistics and data science at Omni Health, and I'm here with my colleague Vic Kumar, who is a senior data scientist at Omni Health. And today we will discuss extracting disease severity measures from unstructured clinical notes using Spark NLP. The talk will be divided roughly in half. The first half, I'll cover disease severity measures themselves. What are they exactly and why they're so important to clinical research and real-world data research. Then I'll pass it over to Vic, where he'll talk about the applications using Spark NLP to extract some of these disease severity measures from the unstructured clinical notes in electronic health record data. And that's basically how the talk will be structured. But before I get into it, I really want to just say a few words about the motivation behind this work, because I really think it's important to put that into the context of the whole thing. So Vic and I are with Omni Health. We're a healthcare data company, and we partner with health systems around the United States and work mainly with their electronic health record data. And what we do is we take their EHR data, we de-identify it, we tokenize it, and we standardize it into a common data model that kind of takes the form of research-ready data sets that are made available to life sciences researchers. And one thing that Vic and I are continuously trying to do is improve the utility of these data sets in our data products. So thinking about what other data elements that are in the EHR that could be incorporated into these products that could eventually provide more value, help push the science forward, things like that with the data sets to help life sciences researchers. And so one of the things that continuously comes up are these disease severity measures, which I'll get into, but oftentimes they're not collected as part of the EHR structured data. Sometimes they are, but most of the time I would say that they're not. And so what we wanted to do was kind of come up with a reliable method of utilizing Spark NLP to actually go into some of the unstructured clinical notes to see how we can extract these measures to incorporate into our data sets for life sciences researchers. So starting with a few definitions, disease severity itself, it really is kind of a generic, let's say broad term that's used to describe the current state of a particular medical condition or disease. And it's usually related to how the patient is feeling at the time or the symptoms that the patient has as it relates to the disease. So just kind of as a basic example, let's say, imagine that you have, let's say, the flu or a common cold, and on day one, probably you're like, I think I might be getting sick, I don't know, and my throat is tickling a little bit, what's going on? And then by day 4 or 5, let's say, you might be in bed with a fever, body aches, headaches, congestion, you can't breathe very well, and just feeling overall miserable. So those are describing two disease states in terms of what severity would be, right? So the first one is really kind of a more mild form of the disease in that state, and the second one is a more severe form of the disease. Now that's kind of an example on a very compressed time frame, but you can imagine for some of these chronic diseases that patients are dealing with, for the majority of their lives, things like cardiovascular diseases, diabetes, some of the autoimmune conditions, things like that. You can see over the course of years and years how it might be important to understand the particular disease state or disease severity that the patient is at a particular time, because that really is going to dictate how the disease is managed itself. And that kind of gets to the last bullet point here, is that severity itself determines the management of almost all diseases. And just to give one quick example from the Omni platform and what we're seeing in the structured data, here's an example from dermatology, Acne vulgaris. So this is the common acne, which I believe is one of the most common skin conditions that exists globally, represents a significant burden on most healthcare systems. But here's a question that's integrated into the EHR system for many of our specialty dermatology networks that are on our platform, that we're lucky that we have this information. So when a clinician goes in and puts in the diagnosis code for acne, this pop-up screen appears and it asks the physician, in your experience among all patients you've seen with this condition, how severe is this patient's condition? And you're left here with, on this example, a 7-point scale that ranges kind of from clear, it goes all the way up to severe. This is an example of something called a PGA, or a Physician Global Assessment of Disease, and it's just the physician's overall impressions of the disease. Now, the reason something like this is important is that when you're typically looking in electronic health records data, you might see on visit 1, the patient has a diagnosis code for acne, on visit 2, a diagnosis code for acne, visit 3, etc. But you really don't know how the patient is doing, right? Is the patient kind of maintaining the status quo of the disease? Is the patient improving over time, worsening over time? How does this correlate with treatment? How does this correlate with other treatment strategies or disease management strategies that might be going on? And so you really don't get that view unless you're collecting data like this. And so with a data point like this that's collected, even one data point, you can do, here's just a very basic analysis we did. That's a Sankey diagram that just kind of shows going from visit 1 to visit 2 to visit 3, how patients are transitioning between some of these, disease states and disease severity. So you can see here that, on going from visit 1 to visit 3, the blue and the green, which is clear and minimal disease, that proportion tends to be getting greater over time. Whereas if you go to the opposite end, the moderate to severe, kind of looking at the red and the orange, those proportions are getting smaller over time. So a picture over time for this population on average is that the patients are improving over time. And so that's just one of the small insights you could extract. Now, imagine correlating this with treatments, changes in treatments, other strategies, other events, and that's where you really can kind of extract a lot more value from the real world data and really apply it to whatever problems you might be trying to examine. So how is disease severity measured exactly? And the answer to that question is that there is no standard or universal way of doing so. It really varies widely depending, number one, on the disease itself, and number two, how easy it is to measure some of these factors. And so I'll give a few examples of how disease severity can be measured. So the first is symptoms. This can be, the absence or presence of a symptom itself, or it could be frequency of symptoms and how often they're appearing. And so I think with this one, a classic example is asthma. So asthma patients in general, they all tend to have the same 4 common symptoms that I think are really common through most asthma. It's usually coughing, wheezing, chest tightness, and shortness of breath. So those are kind of the 4 basic symptoms of asthma that I think is more or less universal. And the way severity is defined is how often they're appearing. So mild asthma is defined as these symptoms appearing on average about twice a week. Moderate asthma is defined as these symptoms appearing on average every day or almost every day. And severe disease is defined as these symptoms occurring multiple times a day, even if you're taking treatments to try to control them, but they're still occurring, right? So here's one example where disease severity is measured or assessed by looking at the symptoms. Another way you can assess disease severity is by physical appearance. And this one actually is very common on some of the skin or dermatologic conditions. So if you imagine something like psoriasis. Psoriasis are these kind of, scaly plaques that appear on the skin. And so sometimes these plaques can actually be raised, right? Rather than being skin deep, they're kind of like actually protrude from the skin a little bit. And the plaques that actually jump out from the skin are considered more severe forms of diseases than the plaques that say are more blended in with the skin or more flat. So that's one example of how a physical appearance can dictate the severity. Staying on the theme of psoriasis, another way is the extent of disease. So here is, let's say you have psoriasis on your finger versus psoriasis, these plaques all over your body. And so how spread out the disease is across your body could be one other measure of disease. Similar with cancer, if a cancer is localized versus if it's something that's spread to other parts of the body, that also shows disease severity. Another way to measure disease severity are complications. And so a lot of diseases, for example, things in dermatology, in the cardiovascular world, in the respiratory world, you might have these exacerbations or flares, they're called, where let's say you just get a very intense combination of symptoms that just happen at one single point in time. And this can last for a day, a week, just depending on the condition, that are typically managed with rescue medication. But in these periods of flares, or these periods of exacerbations, that sometimes is used to define disease severity at that particular point in time versus when a patient is not experiencing these flares. And the last example I wanted to talk about were laboratory and biometric values. You see this a lot with oncology, cardiovascular disease, sometimes ophthalmology. An example from ophthalmology might be, let's say you're measuring diabetic macular edema in a patient, right? And you might look at a patient's visual acuity. So how many letters can the patient read, on the typical eye chart? And that biometric measurement of the eye and just the visual acuity can dictate how severe the disease is because of the actual condition itself. And this list that I provided here is by no means comprehensive or exhaustive. It really is just an example of some. There could be other ways you measure disease severity. It can even be a combination of these things that help you land on what you're going to actually classify as the disease. But I think this does give a good example of the different flavors of how it can be measured. Other characteristics of disease severity that I wanted to mention are the fact that they can be objective or subjective in nature. They can be physician assessed or patient reported, and they can be absolute or relative. And I think on the next slide, I give some examples that I think provide, some different flavors of some of these different things here. So I guess we can start here. Here's just a few examples of disease severity measures. If we start on the upper left, that has kind of the cartoon of the 3 people. This is a measure of body surface area in psoriasis. And I have the links to all these in case you want to look them up and where the source comes from. But with the body surface area in psoriasis, you can see here on the left, mild psoriasis is defined as the condition being on less than 3% of the body. Moderate psoriasis in the middle is 3 to 10% of the body, and severe psoriasis is more than 10% of the body, where they're using the reference of the hand, meaning the hand is equivalent to more or less about 1%. So here's an example where it's physician assessed. It's somewhat objective, somewhat subjective, right? I'm sure that physicians, in the time they have with the patient, aren't sitting there and actually taking measurements of body surface area to the exact, decimal point. But they may eyeball it and say, it looks like you have it on about, let's say, 6% of your body, whereas another physician might see the same patient and say, let's say, 8% of your body. And again, it's just an estimate there. So there is that subjective element to this example of disease severity. Going from there to the left where we have all the faces, this is an example of a visual analog scale, or a VAS, that measures pain. So this is the typical question where they ask the patient, on a scale of 0 to 10, how would you rate your pain right now, where 0 represents no pain and 10 represents the worst possible pain you can imagine. And the patient might say, today I'm feeling like about a 3. Yesterday I felt like a 2. And so this one is an example of a patient-reported outcome, right? So this disease severity metric is coming from the patient. It's the patient experience. It's not the physician saying, I rate you as this. It's the patient himself or herself saying, I feel this way. And that's just one example on the show here, is that how it can come from the patient as opposed to the physician. Going from there, kind of on the opposite end of the spectrum, if we go to the bottom right here, we have something called the MELD score. That's where you see this formula. And that's a tool for measuring severity of liver disease. And you can see it's pretty complicated, right? You take this one lab measurement, you take the natural logarithm of it, you multiply it by something, you add it to this other thing that you've already taken the natural log of, you add this constant, etc. And if you look at the notes, it's actually even more nuanced, right? They say they have a rule. If the patient had dialysis twice in the last 7 days, then this value actually equals this instead of what you measured. So here's an example of something that's really objective, right? You're using exact lab values, you're putting it into a formula, and you get an answer out that has a range. I think this one is, if I'm not mistaken, is between 6 and 40 is what the actual value will be. And the higher your number, the higher your MELD score is, the more severe your disease is. And the MELD score is actually used oftentimes to prioritize patients for who could be a candidate for liver transplant, right? Because the more severe your disease is, once you reach a threshold, you are a candidate to have a transplant. And then the last example I wanted to give here is on the bottom left, which is the RECIST criteria. This is used in oncology to measure disease progression. And so these abbreviations here are, we have CR is complete response, and then you have partial response, stable disease, and progressive disease. And the reason I put this one on here is because it gives an example of a relative measure rather than an absolute measure. So rather than measuring, for example, tumor size at one point in time, you're measuring the change from some predefined baseline. So in this predefined period, progressive disease, for example, if you look at PR, it's defined as at least a 30% decrease in either lesion size or number of lesions. And this would be, this is partial response, excuse me, not progressive disease. Partial response is defined as at least a 30% decrease in the number of lesions or the size of lesions. And that's how it's defined in terms of your disease severity there. So I think this slide here, I think, provides a good flavor of, kind of the different variability you can see when trying to actually quantify or measure disease severity. Some other applications why I think it's important is that it's used oftentimes to measure patient improvement and patient worsening of their condition, which we saw with the acne example that I provided here. It can be used to stratify patients based on underlying risk. And so the risk of a patient experiencing a poor outcome, let's say, could be something that could be of importance when trying to understand the management of the disease. It can help with treatment strategies. It can help with understanding the effectiveness of treatment in the real world. Are patients who are taking one therapy improving or getting worse or staying the same? Disease severity itself is also very heavily correlated with quality of life, and that makes sense, obviously, right? The more severe your disease is, probably the poorer quality of life you're going to have. And the last thing I want to note here is that it's often associated with things like healthcare resource utilization and cost. So when you're measuring some of these health economic outcomes and burden to healthcare system, disease severity measures play an important role there as well. And finally, I want to have this last slide that kind of sets the problem up for Vic to take over, is that, these severity measures that I'm talking about, sometimes they are in the structured EHR data, but oftentimes they are missing. And the extent to which they're documented in the structured data we know that it's not that often. But in the unstructured clinical notes, that's something where we could find the gold, so to speak. We could find some of these measurements documented, and I'm sure there's going to be variability by practice, by disease, by severity measure, et cetera. But ultimately, what we want to do is have a reliable method of applying, NLP, Spark NLP, to some of the unstructured clinical notes in order to extract some of these severity measures. And so we can integrate that into some of these data sets in order for life sciences researchers to kind of have a more complete picture of what's going on within routine clinical care and understanding how patients are progressing through time. So that, I think, gives a good setup to the background of disease severity measures and why they're important. And so from here, I'll turn it over to Vic to talk about the applications of Spark NLP and how we actually extract some of these measures from the unstructured notes.
Thanks, Lawrence, for setting up the problem and introducing severity scores. We're now going to dive into using Spark NLP to extract severity scores from clinical notes. And if you go on the next slide, we have some background. Question answering is an NLP subtask in which a model answers questions about a context. On the right of this slide, you'll see an example of question answering with the context paragraph on the top and some questions and their corresponding answers on the bottom. The answers appear in colored font. This example is from a popular paper released in 2016 that introduced a SQUAD dataset, one of the oldest and most popular datasets for training question answering models. Note that in closed domain question answering, the answer must appear in the context for the question to be answered properly. And as a result of this dataset and others, there is an abundance of language models trained on question answering datasets that are open source and available on the Hugging Face website. And on the next slide, we have some examples of question context pairs we used to extract severity scores. So we just noted on the previous slide that the question answering requires two inputs, a question and a context. The sentences from our EHR clinical notes form the context. What about the questions? To pair the questions with the appropriate context, we made a JSON formatted table similar to that shown here. In the first two columns, you see that we have disease diagnostic code combinations, and we wrote questions for each combination to pair with the appropriate context. For example, for the lower back pain disease, diagnostic code M54.5, we made the question, what is the severity of the back pain? Not shown here are additional columns such as search strings, ranges, answer strings, etc., that we'll get into later, that further allow us to perform quality checks on the answers and the context. So on the next slide, we have a schematic diagram of some of the solution components. So this is a schematic of how our solution works and extracts severity scores from clinical notes. The first step is splitting the note into sentences using Spark NLP for Healthcare's deep learning sentence detector. Once we have the sentences, we narrow down the ones of interest using diagnostic code filtering and keyword filtering, and we'll get into some examples on the next two slides. Third, we then pass the appropriate question context pairs into a pre-trained question answering model using Spark NLP. And fourth, we receive the answer. Finally, we narrow down the correct answers using different quality checks. For ordinal scores, we use keyword filtering to ensure that the answer is what we are looking for. And for continuous scores, such as ejection fraction, we narrow down the correct answers using numerical casting and checking the appropriate range. And on the next slide, we have some examples of continuous example for, we have an example of a continuous severity score for ejection fraction. So here the context sentence, an excerpt of the context sentence is shown, and it reads comorbidities, pulmonary edema, ESRD, HTN, COPD, DM, CHF, EF 40%. So a lot of acronyms. We do our pre-model quality checks. We ensure that the patient has a diagnostic code of I50.9, which is the code for congestive heart failure. And we also ensure that the sentence contains one of the search strings, which is EF. So since both those requirements are met, we now pass this context to the model paired with the question, what is the EF? And the result returned by the model is 40% as a string. So we cast in the numerical portion of that string to 40.0, and we check the range to make sure that it's between 0 and 100, which is a range for ejection fraction. And so the final result is that this patient has an ejection fraction of 40.0. So on the next slide, we have an example of an ordinal severity score for abdominal pain. So here we have a context sentence with some surrounding sentences to improve the clarity of the example. So the context reads, age female here with mild for nausea, vomiting. Had some mild generalized intermittent abdominal pain over past several days. This evening she had vomiting with dinner, exudate or posterior oropharyngeal erythema. Additionally, patient is eating crackers in the room without any difficulty. So we first do our pre-model quality checks. The patient has a diagnostic code of R10.9 in their EHR, which is the code for abdominal pain. Also, the sentence contains one of the search strings, mild. Because both of these requirements are met, we now pass the context to the QA model, paired with the question, what is the severity of the abdominal pain? And we get as a result, in quotes, mild generalized intermittent, which is a string. We then search for the ordinal scores, we search the answer string for certain keywords. And in this case, the keyword is mild. We see that the answer contains the word mild. And so the final result is mild, which is a predefined categorical string. And so on the next slide, we have some of the components of our Spark NLP pipeline. Now that we've gone through some examples, the next step is to write some code. And this slide is for all the Spark NLP users who would like to know how we set up our pipeline. So our pipeline is just a simple one that consists of two components. The first component is a document assembler, and the second component is a span classifier, which is just another word for question answering. Note that the load saved model function allows you to load a pre-trained model from Hugging Face that you've already downloaded and use it with Spark NLP. And that's what we've done here. So now on to some results. So we have, on this slide, we have about 5 severity scores for which we have counts. And we've implemented a total of almost 25 severity scores that are not shown here. These are some of the most common scores that we have found in our data. And you can see that congestive heart failure is the ejection fraction measure for congestive heart failure is the most common score that we found in our notes. You can also see that a variety of medical subspecialties are represented through our severity scores, from cardiology to GI to psychiatry to dermatology to nephrology. Another important part of our work is ensuring that we have accuracy results and that our extractions are highly accurate and of high quality. And on the next slide, we have some accuracy for selected dermatology measures that we've implemented. So the third and fourth rows show that the BSA for psoriasis, the body surface area that Lawrence talked about previously, and the Hurley score for hidradenitis suppurativa, not only are they accurate, but they also are highly, they have high incidence in our notes. So we have implemented those in our solution. Note that the PASI score for psoriasis and the Fitzpatrick scale for dermatology, the first and second rows, are both 100% accuracy, but we only found one sample in our notes, showing that these measures may not be well represented in the notes. Finally, the fifth row, the BSA for atopic dermatitis, is while it has a high count, it has a low accuracy. And it shows that some of the severities, the accuracy varies greatly by severity score. Okay, so on to the next slide, we have some limitations of our work. And there certainly are some limitations. The accuracy could be improved. As we saw in the previous slide, the accuracy is highly dependent on severity measure, and multiple severity scores in the same sentence may lead to some errors, which is what we observed during our accuracy checks. The recall could also be improved, the yield of how many severity scores we're finding for each measure, as not all keywords can be accounted for using this pipeline. Also, the range, when a note specifies a range of severity scores, such as patient presents to the ED with mild to moderate abdominal pain, those are not optimally handled by our pipeline either. And so we must come up with side solutions for these complex cases. But the future directions of our work on the next slide, we want to domain adapt and fine-tune our model to improve the accuracy of our results. And we also plan to implement additional severity score measures across different medical subspecialties in the near future. So we hope that our work will improve opportunities for biomedical and pharmaceutical research across the industry. And that's what we aim to do with our work. Thank you so much for joining our talk, and please let us know if you have any questions. Thank you.